just let me know. All right. So the first thing was immunization timing in pregnancy. Um, just like the basic thing about it is just you're never supposed to give a live virus vaccine to a pregnant woman. So that's like varicella and MMR, which is measles, mumps, rubella. Never supposed to give live vaccines because live vaccines do cause someone to become a little bit sick. So if you ever got like a flu vaccine, so flu vaccine can be an activated vaccine or an inactivated vaccine. So if it's activated and you get it, you can get like a little sick. And you never want to give an activated flu vaccine to a pregnant woman because then she's going to get a little bit sick. And then that can cause some complication to the fetus. So later down the road, the baby may it may cause like blindness, deafness, things like that. So it can just cause some complications to the baby, like when the baby is born. So that's like the whole idea with that. So it has to be given postpartum or like prior to conception, prior to even getting pregnant. Another vaccine that you're never supposed to give that's live is rubella. Um, there's a chart. I'll post that in the group me. There's like a chart of vaccines that you're not supposed to give. I don't think you guys would have to like memorize that because there's just so many that are live and you're not supposed to give. The main ones would just be like measles, mumps, rubella, varicella, and rubella. I'll just add that one. Why are certain vaccines contradicted during pregnancy? It's just the whole idea that you're not supposed to give live vaccines because it can harm the fetus and then it can cause the fetus to like get sick because the mother gets sick and that can cause the baby to get sick, within the uterus. But you can give inactivated vaccines, so those aren't live vaccines. You can give that to the mom. So the flu vaccine it could be activated or inactivated. If the mom's pregnant, then you're going to want to give an inactivated one, and Tdap as well. Contraceptive methods. I honestly wasn't tested like too much on contraceptive methods, but I just saw some of these from ATI. So rate contraceptives from least to most effective, spermicides, withdrawal method, condoms, oral contraceptives, IUDs, and then implants, which is Nexaplanin. This is like it's like an injection that they implant and it goes under the skin. But yeah, IUDs are also very like effective. They can cause like blood clots and certain things, so can like some oral contraceptives. So they do come with risk, but they are more effective than the first three. What factors affect effectiveness? Proper use. So just like education and everything as well. Compliance and interactions with medications, and always patient education. But whatever notes you guys have on that, I don't really have too much with this one because I was never really tested on these. Gestational diabetes management. So I just went over just a little bit about gestational diabetes. I added a little bit of additional notes just so you can just get like what it is and everything. But it's just temporary diabetes related to pregnancy. So around 24 weeks gestation, whenever you see that it says gestation after the weeks, that's just saying 24 weeks pregnant. So it usually starts around 24 weeks. When the woman's going to start showing like signs and symptoms of diabetes where her glucose levels are super high, and then we're going to we're going to manage that. Mainly insulin is like the main source of how we'll manage it, but we'll talk about that. So basically the whole idea is that pancreas is unable to meet increased metabolic demands for insulin production. Just a fancy way of saying that the pancreas isn't producing enough insulin. Insulin puts glucose into cells. But if we don't have enough insulin, there's just a lot of free flowing glucose, which can be very unsafe, and hyperglycemia, decay, all those complications that can happen. High risk. Some patients are high risk, especially if you've had gestational diabetes in the past with other pregnancies, previous pregnancies, or if you even have like diabetes that runs in the family, or even high BMI, things like that. Low risk. So regardless, Every woman who is pregnant will be tested for gestational diabetes. It doesn't matter. Like every single pregnant woman will be tested. And this test happens around 24 to 28 weeks. Um, so these are the laboratory monitoring and how like we'll diagnose someone with gestational diabetes. And just to let you know, gestational diabetes is temporary diabetes. So she'll have diabetes when she's pregnant, but when she gives birth to that baby, it goes away. So she'll no longer have it. But if you've had gestational diabetes, it does place you at higher risk for later in your life to get type 2. Like my mom had gestational diabetes when she was pregnant with me, and a few years later, she got diagnosed with type 2 diabetes. So it does increase your risk of getting type 2 later in life, but not always. So
So, oh, sorry,
no, you're good.
ACOG, that's the test? That's the test?
Oh, that's not the taste. This is just like a resource. My professor that I had, she was like very like reading articles. So it's just
Oh,
this
okay.
article, yeah. So these are the labs. So every single woman will do the 1 hour glucose tolerance test. Every woman who is pregnant um, will do the 1 hour glucose tolerance test, and this is going to happen from 24 to 28 weeks within that range. So it's a screening. So just know the difference between this one and this the 3 hour one, which we'll talk about. A woman will only do the 3 hour one if the 1 hour one is just indicating that she may have gestational diabetes. Remember the difference between screening and diagnostic tests. So screening means like you may have it, but you may not have it. It just shows like a probability, like, okay, like you are showing signs of it, but you may not have it. But the 3 hour screening is diagnostic. Whenever you ever see like a diagnostic test, um, this means that you 100% have it. It's diagnostic. So that's just the difference between screening and diagnostic. So first we're going to do the screening. We'll be like, okay, we'll see if you're showing that you may have it. So it's basically a sugary drink. They're going to put sugar in like liquid, mix it, and then the woman's going to drink it. And then the woman's going to actually have to wait there at the doctor's office for like a whole entire hour. And then they're going to check the woman's blood glucose, usually just a finger stick. And she doesn't have to, there's nothing to prepare for, so she doesn't have to fast before this. And it does occur during the prenatal visit. So say we do the blood test, all right? You finger stick her and it comes back that it's greater than or equal to 130 or 140 after that 1 hour. She drank the drink, she waited an hour, you check the blood, and it's showing that it's 130 or 140. This requires further testing because, that's telling me that she may or may not have it, but she may. So we're going to have to do further testing to see if she actually has it. All right, so this one is a screening. So it's like she may, but she may not have it. The next one, so say it was at 145. That is not a good sign, but we're not 100% sure if she has gestational diabetes just yet. So we're going to tell the woman to come back maybe within a couple days or in like a week or two. And she's going to have to do the 3 hour glucose tolerance test. And just to say, this one is a 50-gram load, and all that's saying is you're giving this woman 50 grams of sugar, all right, in the drink, and you're gonna like mix it up. This one here is a 3 hour glucose tolerance test, and you're gonna be giving the woman 100 grams of glucose and mix it in a drink. And remember, this one is diagnostic, so it's gonna tell me if this woman 100% has gestational diabetes. So she goes to the lab, she has to fast. With this one, she didn't have to fast. This one, she does have to fast. She has to be NPO for at least 8 hours. She's going to drink that 100-gram sugary drink, and then she's actually going to have to wait an entire 3 hours. So, that could be a bit annoying for them. They're going to have to wait in the lab for 3 whole hours. And then you're going to do another blood draw. You're going to do a blood draw here. And gestational diabetes is diagnosed if 2 levels are met or exceed. So fasting, we'll do this when she comes in. So this whole entire 3 hour glucose tolerance test is within a 3 hour time frame. So when she first comes in, that's her fasting blood glucose. If it's greater than 95, 1 hour if it's greater than 180. So after 1 hour of being there, say so she waited an hour after taking a sugary drink, and say if it's at 180, that's not good. After 2 hours and it's greater than 155, and then she waited 3 full hours and it's greater than 140. So you're drawing, you're doing the finger sticks 4 different times. So right when she comes in, and then she's gonna drink the sugary drink. So after 1 hour, then after 2 hours, and then after 3. So at those intervals, you're gonna be taking blood. But just remember that 2 levels have to be met. So say only 1 was met. So say she came in and it was at 98, but then all of these were less than this range. Then she doesn't have it. But if say this was like 98 and then this one was 190, then she would be diagnosed. So at least 2 levels need to be met. Any questions with these tests? Because I feel like you're probably gonna have a question with these.
No, not really.
Okay, that's good. And then the other test is just like a blood test. So hemoglobin A1C. So if you think back to like med-surg, hemoglobin A1C is like a good indicator if someone's managing their diabetes well, but it also indicates if someone may have it. So we always want hemoglobin A1C to be less than 7%. If it's like more than that, then that's very alarming. Some sources say less than 6.5%, but I feel like it's mainly just like less than 7%. If say someone has like an 11% hemoglobin A1C, that's very alarming. Not managing the diabetes well, or indicative that the person does have diabetes. And then you can also do a fasting blood glucose, which we talked about here. But the main ones for like the pregnancy is going to be these 2. But you only do the 3-hour one if they were greater than 130 or 140. Then you only do the 3-hour at that time. So say you did the 3-hour one, 2 of these got met, or maybe 3 of them got met, or 4, but at least 2. And now she has gestational diabetes. So how is she going to management for this time while she's pregnant? So the first thing that you're going to talk about with this patient is just lifestyle nutritional changes. You may want to refer to a diabetes educator, and carb counts just for better education. This woman needs tight control and glucose monitoring. So you want to teach them, how to finger stick. They do want their fasting blood glucose less than 90, and then 1 hour postprandial, which means after eating, should be less than 140. Increased fetal surveillance. So we're just this is a high risk pregnancy now, especially if someone has gestational diabetes, because there's so many complications that can happen. So we're going to want to educate this mom that she needs to do kick counts. So she's going to have to lay on her side, and she's just going to have to just lay there and stay awake and just count how many kicks she gets in an hour. Because say she's not getting any kicks in 2 hours, that's very alarming, especially within that 3rd trimester. That baby should be kicking at least 2 times an hour. And then there's also a non-stress test, and biophysical profile, which can also can track how like the baby's doing and everything, and how their heart rate is. I wouldn't worry too much about this. It wasn't really on the blueprint. Insulin administration and management. So insulin does not cross the placenta, which is good. So it's commonly short and intermediate acting insulin because it doesn't cross the placenta. And usually the woman will do injections for gestational diabetes, so the sub-Q injections. So these are just mainly the management: diet, exercise, insulin, and then oral diabetic medications. I'm just going to skip that because there's not in the blueprint. I just added a little bit more information. Intrapartum, that's just during pregnancy. Induction at 39 weeks, because since the size of the baby will increase, that will increase the risk of complications. So the whole thing with this is saying is just women who are pregnant and they have diabetes, the gestational diabetes, their baby is at a high risk of being macrosomic. So it's gonna very at risk for becoming like a very big baby. You have a lot of extra glucose floating around. The baby's at risk for becoming bigger. Um, so, they're gonna induce her a little bit earlier just so that the baby doesn't get super big where now the baby cannot fit through the birth canal and it can lead to other complications and she would have to have a C-section, things like that. So just having baby a bit earlier just because the baby is at risk for becoming bigger. Postpartum, maternal insulin requirements for GD falls dramatically after delivery, and placental delivery. So the whole thing that I was just saying is that after the woman gives birth, she delivers the baby, then she delivers the placenta, she's no longer having diabetes because it was only just gestational. But it does increase the risk of, the mom getting type 2 diabetes later in life. Pharmacological interventions. So insulin is preferred just because it does not cross the placenta. So most of the time, they're just going to do a sub-Q injection. There also are oral agents like metformin or glyburide, but most often it's just insulin is preferred just because it doesn't cross to the placenta, so it doesn't get to the baby and doesn't cause any side effects or complications to the baby. Next is magnesium sulfate. This is a very important medication, especially if you're dealing with a patient who has preeclampsia. So that is just like hypertension during pregnancy. So it's pregnancy-induced hypertension. The pregnancy is causing it. So it's used for seizure prevention in preeclampsia and tocolytic in preterm labor.
I'm sorry, could you repeat that again, please?
About
The
preeclampsia?
preeclampsia? Yes, please.
Yeah, so preeclampsia is it's pregnancy-induced hypertension. So women who are pregnant, they'll, I think we'll talk about that a little bit later, like the preeclampsia indicators, but mainly they just have pregnancy, which is causing hypertension. So we're gonna have to manage that. So if we don't manage preeclampsia, then the woman is at risk for seizures. If we don't manage this hypertension, then she's at risk for a lot of different things and also a lot of seizures happening. So preeclampsia, if not treated well, I feel like I can never spell it right. Eclampsia. If not treated well, it can go into eclampsia, which is, I'm not spelling it there. So I'll just read it. So you don't manage this well, it can develop into eclampsia, which is seizures. It's pregnancy-induced hypertension as well, but this time it's with seizures. And seizures are very dangerous just because with seizures, it blocks your airway. And that's what the mom's at risk for. That's why seizures are a really big no-go, especially with pregnant women. Decrease oxygen to the fetus and all things like that. What are signs of magnesium toxicity? So with magnesium sulfate, this medication helps to prevent those seizures from happening, to prevent eclampsia. So say she has a blood pressure, say the woman is in her 3rd trimester and her blood pressure is 200 over 120. That's very high. With hypertension, all it is just it's causing a lot of vasoconstriction. And if you have a lot of vasoconstriction going on, say you have vasoconstriction going to the placenta, then you can't get any blood flow to the placenta, and then you don't get any blood flow to the baby. So just think vasoconstriction, hypertension. And we'll talk about those side effects a little down here. So this medication helps, with that, and it helps prevent those seizures from happening. We don't want preeclampsia going any further, getting super super high where now it's causing seizures. So this medication helps with that. So this medication is very can be very dangerous because it affects respiratory rate and everything like that. So what signs of magnesium toxicity? So the therapeutic level. So as the nurse, you're going to be the one who's going to be drawing the blood. So the therapeutic levels is 4 to 7. So you need it to be within this range. If it goes above 8, it's toxic. It's a toxin now. Um, you know, if it goes above 15, then respiratory arrest and cardiac arrest will be happening. That patient will be coding. She never wanted to get above 15, but even if it's above 8, you're going to have to intervene really fast because we just don't want the woman to now have cardiac arrest and things like that. So these are going to be your main signs and symptoms. So decreased respiratory rate less than 12. So the higher it gets, then you're going to see that respiratory rate, decreasing. Decrease in absent deep tendon reflexes. All right. Hypotension. So just think that like everything is going down if this medication you're experiencing toxicity. Urine output less than 30 milliliters per hour. So remember, normal urine output, you always want it to be at least 30. It always has to be at least 30 for it to be normal. So now here with the toxicity, you have it less than 30 milliliters per hour. Altered level of consciousness, cardiac arrhythmias, EKG changes, and then like we talked about, these are your levels. And so I think everything's just like decreasing. That happens with a lot of toxicity with medications where everything is decreasing, but this one is just very alarming because now it can possibly cause cardiac arrest, respiratory arrest. And these are normal side effects. Some people will think that it's like not normal, but these are normal side effects. So if you ever get a question like this, so feeling heavy and hard to move it. There's like typos. This medication is a smooth muscle relaxant, so this woman's gonna feel very heavy. She's not really gonna want to move, and then have a little bit of sweaty, and then flushing as well. A little bit of redness in the cheeks. Those are completely normal though. The main one is like feeling heavy and hard to move. I just saw like a woman who gave birth. She had preeclampsia and they put her on this medication. And then she said that she was feeling very heavy and she didn't want to move. That's a completely normal side effect. So a lot of women will experience this. And it's just sweating and flushing of the skin. So what nursing interventions are necessary when toxicity is suspected? So say it goes above 8. You're going to stop this infusion, administer calcium gluconate. This is your antidote. So it's going to reverse the effects that magnesium sulfate just caused. It's going to reverse the toxicity. And then you're going to want to notify the doctor, and then you're going to want to do continuous monitoring of the vital signs. You want to make sure that it's going up now. You just administered the antidote. We want to make sure that the urine output is now 30 and above. We want to make sure that the patient's not super hypotensive or crashing or have a really low respiratory. Everything should be increasing now because we just administered the antidote. We also want to monitor the deep tendon reflexes for effectiveness because preeclampsia patients have hyperreflexia. So I just want to make sure the deep tendon reflexes are now there now and not absent or very decreased. And then intake and output. Because like we said, you want a urine output 30 and above. If it's less than that, that's not normal. That's very alarming. It's something that the kidneys are not doing their job and they're not working well. All right. So this is a little bit about preeclampsia. So these are the clinical manifestations of mild versus severe preeclampsia. So mild, there's only an increasing blood pressure, so like greater than 140/90, but it doesn't include like other organs being affected. So with hypertension, you do have vasoconstriction. That's what you need to remember here. Hypertension, any type of hypertension, that is vasoconstriction. So whenever you have vasoconstriction, you want to think you're not getting proper blood flow to an organ. So say you have a lot of vasoconstriction, like, let's give an example. So you have a lot of vasoconstriction by your arteries to your kidneys. What do you think can happen? You're gonna have decreased perfusion to the kidneys. The kidneys aren't going to be able to do their job, and then there's going to be decreased urine output, less than 30 milliliters an hour. So that's just a bit of an example. We're going to go into the effects in a bit, but just know that with mild, it's just an increasing blood pressure, which is alarming, but it doesn't include other organs. It's not affecting the kidneys. It's not affecting like certain organs. It's just an increasing blood pressure. But with severe, it's a multi-system disorder, which is very alarming. Just always think vasoconstriction with this one, where now it's affecting different organs. So blood pressure is greater than 140/90 after 20 weeks of pregnancy, accompanied by protein in the urine, proteinuria. It's gonna be 1+ or more. These are the very like important indicators. Like even as I'm doing like practice NCLEX questions now, like it's always like what is indicative of preeclampsia. It's going to be, very high blood pressure, and then it's going to be proteinuria. So you're going to do a urine dipstick, and then you're going to see that there's protein in the urine. That's very alarming. And then thirdly, you're going to see, especially if it's severe, you're going to see that this woman's experiencing a lot of side effects, blurry vision, headaches, things like that. So it just depends on where, the vasoconstriction is happening. Say she's having vasoconstriction happening, near the head. She's gonna have a headache, vision changes. If she's having right upper quadrant pain, remember what's there? It's the liver. The liver is there. So now she's having pain at the liver. There's decreased perfusion to the liver. Hyperreflexia is a very key characteristic of preeclampsia as well, where the deep-tending reflexors are just reacting super quickly. And you just always want to think about patients' baseline. So numbers are not always clear, so always pay attention to patterns. So for example, if systolic increases by 50 or 20. The whole thing with severe preeclampsia is that it affects multiple organs. And then your whole goal with this is to prevent seizures, to prevent eclampsia. You want to prevent eclampsia, which is those that hypertension with the seizures now. So the ones that we just talked about up here, they're not dealing with the seizures. But say the mild hypertension goes untreated, then we can go into severe hypertension, and now it's affecting other organs. And say we don't treat severe preeclampsia, then we're gonna go into eclampsia, which is the seizures with the hypertension. So this is just a way to remember what you're going to see with preeclampsia. You're going to see protein in the urine, so proteinuria. You're going to see raising blood pressure, and you're going to see edema as well, within the feet and everything. Any questions? I know it can sound a little complicated.
No.
Okay. So these are the manifestations that the mother's going to have. So, she's going to have the hypertension and also protein in the urine. She's going to have epigastric pain. So this is pain top of the abdomen by the liver. Headaches, visual disturbances, blurred vision, and brisk deep-tending reflexes with clonus. And that's just saying that it's just the deep-tending reflexes are super fast. So I always think vasoconstriction, especially if it's near the head, this can cause headaches and visual disturbances like blurry vision. Like I said, if you have so much vasoconstriction, now you're having decreased perfusion of the kidneys. The kidneys cannot do their job properly. They can't filter all the urine, and now there's going to be decreased urine output. So less than 30 milliliters an hour. And then you have increased sodium, BUN, uric acid, and creatinine. So just know that these are always your like indicators. If the kidneys aren't working well, especially BUN and creatinine, these are blood tests. So if they're elevated, like very elevated, that's telling you that the kidneys are not working properly, which makes sense in this case. So if the kidneys aren't being perfused properly, they're not working properly. So we'll see these labs are increased. Generalized non-specific edema and pulmonary edema. So it's just this little acronym helps you remember that edema is also like a little side effect that can happen with this as well. Manifestations via assessment. Brain, so any unusual headaches, any visual disturbances. You want to see if any deep-tending reflexes are out of range. lungs. So say if the lungs aren't being perfused well and there's a lot of vasoconstriction happening, is she having any trouble breathing or any chest pain? If there's any vasoconstriction happening near the liver, the arteries that supply the liver, then any abdominal pain, any right upper quadrant pain, vasoconstriction to the kidneys. So that's decreased perfusion to the kidney. So any change in urine output, the urine will be more concentrated, urine output will be decreased. So it won't be normal, it won't be greater than or equal to 30, it'll be less than that. Is there any protein in the urine? That's a very key indicator of preeclampsia, like he said. And then, is there any increase in these levels? If these are increased, it's telling me that the kidneys aren't doing their job properly. They're not filtering the urine the way they're supposed to. Placenta. If we have vasoconstriction, which means decreased perfusion of oxygenated blood to the placenta, then that's really bad because now we don't have any perfusion going to the baby. So is there any decrease in fetal movement? Like, it's like, the woman needs to tell us how many kicks she's had in an hour. She said she hasn't felt any kicks in like an hour or two. That's very alarming. Scan generalized edema. It could be pulmonary. It can be that lower edema as well. Reflexes, deep tendon reflexes. She's gonna be very irritable. So those deep tendon reflexes are gonna be very fast, 2+. So your deep tendon reflexes should always be 2, but here it's going to be over 2, so 2+. The fetus, so there's so much vasoconstriction happening because of this hypertension, and now we have poor placental perfusion. So placenta is not getting oxygenated blood, so there's going to be intrauterine growth restriction. All that means is just a fancy word saying that the baby's not able to grow properly because it's not being supplied with nutrients and the oxygen that it needs. Also, it can cause abruption of the placenta. All that is saying is that the placenta, because the placenta is attached to the uterus, it's saying that the placenta is now detached from the uterus, which is a medical emergency. And then fetal hypoxia. So there's so much vasoconstriction happening where the placenta is not being perfused, baby's not being perfused, so then fetal hypoxia and fetal distress. And this was on your blueprint. What are the risks and complications associated with preeclampsia? So if we see mild preeclampsia and severe preeclampsia, and we don't intervene, then this woman's going to develop eclampsia, which is that preeclampsia with seizures. So the whole thing is just you're gonna see mild at first. She comes to her checkups. So this women do go through a lot of checkups during their pregnancy. You're gonna see mild preeclampsia. Say you don't treat that effectively and you just overlook it. And then the next checkup, you see that the blood pressure gets very severe, and say there's no intervention at all or anything, then the woman will progress into eclampsia, which is preeclampsia with seizures. So with the milds, that is just you just have hypertension. You just have a blood pressure that's greater than 140. Was it 140 over 90? Yeah, greater than 140 over 90. If it's severe, you're dealing with a blood pressure that's greater than 140 over 90, but now you're dealing with it affecting other organs, where it's affecting perfusion to organs, like all those signs and symptoms we said. And like when you're studying, I remember when I was studying, I just like would go from head to toe and just think like, okay, I'll start from head to toe and be like, okay, brain, what can happen here? Always think vasoconstriction and what can happen, and just think brain, and just go down your body and just think like, okay, what can happen according to body system. That's just the way I like studied for the, my test with this. So this one just a very high blood pressure, and now it's affecting perfusion to organs. And say this doesn't get treated, this woman does not get the magnesium sulfate she needs, or she doesn't get those hypertensive medication she needs, then she's gonna go to eclampsia, which is all the same things as severe, except this one is the one with seizures. This one isn't with seizures. This one is neither. This is the one with seizures. So we want to prevent that by giving magnesium sulfate early on, especially with the severe one. The mild one, you're not going to give magnesium sulfate. You're going to give magnesium sulfate with the severe one. Another complication is HELLP syndrome. So you'll notice the side effects in the mother. So it stands for hemolysis, which means destruction of red blood cells. So you're going to know, you draw the blood, you see the red blood cells within the mom has decreased significantly. Elevated liver enzymes. So this tells me, you draw the blood, you see on the labs that it says that there's very high liver enzymes like ALT, AST, GPT, and that indicates liver damage. I'll just write that. I don't think your teacher would put this on it, but it says AST, ALT. Those are your main liver enzymes, and if you ever see those elevated, that says that there's liver damage. And then you're also going to see a low platelet count. So remember, platelets, if they're low, that indicates bleeding. If they're high, that indicates clotting. But here, complication would be low platelets. Normal platelets is 150,000 to 300,000. So if it's less than 150, low, and that signifies bleeding. And then another complication that can happen, which we talked about up here, abruption of the placenta. That's when the placenta separates from the uterine wall, which is not good because then the baby's not getting any oxygen. Placental abruptions can be partial, where some of it has come off the uterine wall, or complete. And complete is like a medical emergency where they're most likely going to do a C-section. But that was not in the blueprint, so I wouldn't focus too much on.
So for mild preeclampsia, they don't take magnesium sulfate. That's only for severe.
Yeah.
Right?
So yeah.
Okay.
So with mild, you're probably just gonna do like try to manage it with your beta blockers or ACE inhibitors, things like that. And then say she comes in, the woman's blood pressure is like skyrocketed. It's like 200 over 120. That's very severe. And now she's saying she has side effects of blurred vision, right upper quadrant pain. She doesn't feel her baby kicking. That's a sign of severe, where we're going to have to immediately put her on magnesium sulfate and maybe some hypertensive medications as well. And that's all just because we want to prevent those seizures from happening. Does that make sense?
Yes, thank you.
You're welcome. Do you feel okay with this? I know it's a lot of information.
No, I do. Thank you.
I feel like we're getting to the more easy stuff now. So estimated due date, this isn't too bad. It's just the last menstrual period. So if your teacher wants you to calculate it, she's going to have to give you the last menstrual period. So she'll give you a date, and then all you're going to have to do is subtract 3 months, add 7 days, and then add 1 year. So this is just an example. So if it's June 10th, subtract 3 months. You'll get March 10th. I put the years here too, just so it's better with practicing. I know one of your classmates had a question because of they were like, oh, I shouldn't add the year, but you do have to add the year, because if you don't add the year, then you're saying that she's gonna have that pregnancy before her last menstrual period date. So you do have to add the year. So June 10, 2024, you're gonna subtract 3 months. And you get March 10th, 2024, and then you're at 7 days, March 17th, and then you're gonna add 1 whole year, and that's gonna be March 17th, 2025. So that's just the estimated due date. Yeah, sometimes I ask questions like this. I've seen this on like Archer and some NCLEX questions too, so it might even be like an NCLEX thing too. Umbilical cord anatomy. So the whole thing with that is that there's, just know that the acronym AVA, it helps you with it. There's 2 arteries and 1 vein. And it's opposite of like how arteries and veins are for us. So normally in us adults, we have our arteries that carry oxygenated blood, to our organs and everything, and then our veins carry that deoxygenated blood back to the heart. But here, the anatomy is different when babies are in the uterus. So the vein actually delivers oxygenated blood to the baby, while the arteries carries waste back to the placenta. And it's just opposite from us. I feel like I phrased wrong, from us humans. I'm gonna say opposite from like how we are outside of the uterus. It's just this is happening because they have that umbilical cord that's providing nutrients and oxygen to them. Um, and then it's also surrounded by Wharton's jelly. So let me just find a picture. So it's like you have your two arteries and then your one vein. So this is, carrying all the oxygenated blood and everything. And then the arteries are carrying, all the waste back to the placenta. And then it's surrounded by Wharton's jelly. So this is Wharton's jelly. It just helps protect the umbilical cord better and everything like that. So you can like see it there. That's what it's surrounded by. Let's see. All right, so that's that one. I feel like it would just be a question like two arteries and one vein and what they do. You know that they're opposite of how they are like with us. True versus false labor. So what signs distinguish true labor from false labor? I put a little chart here, but true labor, these contractions are going to be regular and increase in intensity. So regular by meaning like they're happening in a pattern. So if you ever see like on TV shows, they're like, oh, the contractions are happening 2 minutes apart. That's a sign of true labor because there's a pattern, there's consistency happening here where they're happening every 2 minutes. But if it's false labor, like those Braxton Hicks contractions, those are false labor. I'll just put that. They're irregular. So say like, oh, they're timing it, but the contractions are happening. They just happened 3 minutes ago, and then they happened 5 minutes later, and then they happened 10 minutes later. They're not consistent. They're very irregular, and then they actually stop. If the woman walks or she stops activity, it just stops. Here, it's just not gonna just stop if you sit down or walk or anything. The main difference, which I feel like they might test you guys on, is just that with true labor, you're actually going to see cervical changes. So the cervix is actually going to dilate here now. We're now, dilation, the max it's 10 centimeters. And then it's going to efface, which means that the cervix is now thinning. Because we want the cervix to be very thin and we want it to be very wide so that baby can come out nicely and smoothly. So now we're going to see cervical changes. So that signals to me that this is true labor. With the false labor or the Braxton Hicks contractions, there's no change in the cervix. There's no dilation happening. There's no effacing. That cervix is not thinning out like it's would be with true labor. And then just discomfort changes. So discomfort with true labor is going to be felt in the back and radiates to the abdomen, and then with false labor is going to be felt in the front only. And this is just sort of repeating it. These are my notes from OB last year. So false labor, no progressive cervical changes. Contractions are inconsistent in frequency, duration, and intensity. There's no pattern. They're not strong enough to cause any cervical changes like effacement and dilation. They may stop or slow down with walking or position changes. Hydration slows or stops contractions. Preterm labor also. So it just can stop the false labor. And then this one, with true labor, there's progressive effacement. Effacement is measured from, I don't think I put that in there. Effacement is measured from 0 to 100%. And then dilation is measured from 0 to 10 centimeters. So say the woman is 100% effaced and then she's 10 centimeters dilated. When that happens, she can start pushing when it's there. Right? We want the woman fully dilated and fully effaced, and then she can start pushing. But say it's not like at 10 yet or at 100 yet, then she shouldn't be pushing just yet, just because the baby's not gonna be coming out smoothly or anything. The baby wouldn't be able to fit if we're not fully effaced or dilated. But with here, true labor, we see cervical changes, we see effacement, we see that cervix thinning, and we see dilation as well. contractions become closer together. So say she was having it 5 minutes apart. Now she's having them 2 minutes apart. They're just coming closer together, and they last longer as well. An increase in intensity. So a good labor pattern, you want a contraction for at least 60 seconds long and occurring about every 3 to 4 minutes. So pain starts in back and radius toward abdomen, and contractions continue no matter what the mother does. Like with false, if she, changes her position or sits down or has a little bit of activity, it stops. But here, no matter what she does, it's going to continue because it's true labor. What changes in the cervix? Oh, I did put it. During true labor, the cervix undergoes progressive dilation and effacement. So dilation is opening of the cervix from 0 to 10 centimeters. Effacement, thinning of the cervix from 0 to 100%. These changes occur due to regular uterine contractions that increase in intensity and frequency. In true labor, the cervix truly changes. So that's the main thing with that. We're actually going to see these two things happening, and we're going to see the intensity, duration, and just the contractions becoming closer. Magnesium sulfate was also in your blueprint, but it also is used whenever you see the word tocolytic, those medications stop labor, so they stop preterm labor. Used to delay labor and neuroprotection decreases risk of cerebral palsy. So that medication also does help with neuroprotection, so protecting that fetus from getting like cerebral palsy or anything like that, but also used as a tocolytic, so used to delay labor, especially preterm labor. So say a woman is having contractions and she's going into preterm labor, what this medication is also going to do is going to stop those contractions from happening and then stopping preterm labor. Assessments, when administer magnesium sulfate, all the same things we said before. You want to assess the respiratory rate, the urine output, the depending reflexes, all things like that. Because remember when we said like magnesium sulfate toxicity, everything's going to get super, super decreased. So you just want to assess everything, vital signs, especially your respiratory rate, because if that's decreasing, less than 12, that's very alarming, sign of toxicity. If those depending reflexes are completely absent, that's very alarming as well. If that urine output is less than 30, that's very alarming too. So we just want to make sure that toxicity is not happening. So remember, 4 to 7, greater than 8, toxicity, greater than 15, that, respiratory arrest, cardiac arrest. Tocolytic therapy. So when is a tocolytic therapy indicated or contraindicated? So tocolytics are medications to stop contractions from happening, especially in women who come in with babies who are, less than 38 weeks, because full term is 38 to 40 weeks. Anything less than that would be considered preterm. So, and you never want to have a preterm baby just because the lungs are not mature yet. And the baby wouldn't be able to really breathe on their own yet. The alveoli and everything within the lungs is not fully formed yet. So the baby wouldn't be able to breathe on their own. So that's the main thing why we do not want that baby to be coming out less than 38 weeks. So that's why we're going to use a tocolytic, just to prevent those contractions. And if you're preventing those contractions, you're preventing those cervical changes, and you're preventing that baby from coming out. So it's used to stop the preterm contractions. Contraindications, if there's an infection or fetal distress or preeclampsia. These are the meds for preterm contractions. So nifedipine, which is your calcium channel blocker, terbutaline as well, and then indomethacin, which is an NSAID. Those are medications that can help stop preterm contractions. Next. I might go a little bit over the time, so it's okay if you can't stay the full time. I'll just keep going now so I can finish it. So fetal presentation and assessment. So this is how the fetus is presenting within the uterus. So your professor put on the blueprint breech position. Breech position is abnormal, and we do not want that to happen. So normal fetal position that we want is this one right here.
Phallic, right?
Yeah, that's what you want. You want the head first. And you actually want the baby to be I'm gonna keep zooming. You actually want the baby's back to be facing the mom's belly, if that makes sense. Which a lot of people are like confused about at first, but I put this in here. Did your professor teach about this?
Yeah, she did.
Yeah, so like with this, like as a nurse you would have to like document like how the baby is presenting in the fetus. So if it's a phallic, that's what we want, but we can right or left is fine, but we do want the baby's back to be facing mom's belly. um so it'd be like here, this is left occiput transverse, where the baby's not facing either front or back. Posterior is when the baby's back is on mom's back, but we do want the baby to be either right occiput anterior or left occiput anterior. These are ideal positions to have the baby come out, just because we want the baby's head to come out first, and then the baby on its own through maneuvers face will come out nicely. We never want like the foot coming out or anything like that, so it's not gonna fit right and things like that. I keep zooming out. All right, so just know that's the phallic, and we do want the baby to be anteriorly facing the mom. So they're back by mom's belly, like mom's front. So breech is abnormal, so the buttocks or the feet are coming out first, and we never want that to happen. We do want the baby to be occiput or cephalic, so head first, meaning head coming out first. So identified via Leopold's maneuvers or ultrasound. So Leopold maneuvers, which we'll talk about, are maneuvers that like you're going to be feeling or the doctor's going to be feeling, just to see like how that baby's presenting. We can also do an ultrasound as well. So if the lower half of the body comes out and their head is too big to come out, there's a problem. All right. 2.5 of all babies are breech, which is unusual because the head is the heaviest part of the body. So usually like gravity, the head will come out first. So there's different types of breech. So if it's a complete breech, that's just saying that the baby butt is first, and then both hips, this one, both hips and knees are flexed like this, so they look like a little Buddha here. If it's frank, both feet are up and against their face. If it's a footling, the feet's coming out first, which we never want to happen, because then you would have to be like yanking their feet, and it just wouldn't come out the right way, and then a foot can get stuck behind the pubic bone, things like that. We never want a breech baby. And then we can do a version if a baby is breech. So that is just saying that we're gonna you can manually do this, where the doctor is going to like go in with, well, not go in with their hands, but like their hands are gonna be on the mother's abdomen. They're gonna be trying to rotate that baby into the proper position. So it's definitely gonna be very painful for the mother. And there's another abnormal fetal position, and that's transverse, where the baby's lying horizontal. That's that one. So breech and transverse are abnormal, but then with breech you do have different types, as you can see, just depending on what's coming out first. Is the butt coming out first, or is the foot? Things like that. The ideal presentation is head, like you said. Like we do want cephalic, so head coming out first, or vertex. Those mean the same thing, but you're never really going to see vertex. Like I never seen that anywhere, like on NCLEX questions or even on like my test last year. It's always going to be like cephalic. But your teacher just put breech, but I just think it's important just to know like the differences and what's normal. So the head is entered pelvis first, is what we want. So 95% of all babies present cephalic. So ideal position is occiput anterior position. Occiput means head first. Anterior means we want the baby's back towards mom's front. That's what we want. And then just occiput anterior position is the ideal. Most people think that like you want the baby's like front coming out first, but we don't want that. It's just not ideal, because it can lead to certain complications. So we do want babies, like baby coming out this way, and then through certain maneuvers, then the baby comes out. So those are the ideal position. Leopold's maneuvers. So this is external palpation of the uterus through the abdomen to determine the presenting part, how the fetus is lying, fetal attitude, and point of maximal impulse. So even like the heart rate of the baby. So it determines placement of external transducer for fetal monitoring. So if you've seen in clinical, they place that like belts around the mom's belly, so that helps with the heart rate and seeing the heart rate and everything like that. So they're going to palpate above the pubic bone and pinch the presenting part if part is pushed upward, not engaged, if difficult to move, engaged in maternal pelvis. Has your teacher gone over engagement with you guys?
I'm gonna be honest, I don't even remember about engagement.
I'm gonna see. I have my other notes from last year here. I'm just gonna pull it up real fast, because if you want to look at these notes that I have from last year, it is a lot of information. I think it's more information than what your teacher is teaching. I did post these too. I would just focus on your blueprint, just because it's mentioning engagement. I'm just gonna briefly go over it, and if you do want to go into L&D, then it's just like important to know where is engagement. So with engagement, this is just telling me like when the baby, so this is how a baby's like coming out. So we like measure that in centimeters, and say she gets to 0 here, that's telling me that she's like in the maternal pelvis. She's there. The baby is coming through the birth canal, and just making its way through the pelvis. When the baby gets to 5 station, then the mom can start pushing. But when it's at 0, it's telling me that the baby's at the ischial spines. So the baby's progressing the way we want the baby to be progressing. But when the baby gets to 5, then the mom can start pushing. But if she's up here, there's no point for her to push yet. So that's all it's just saying. So that's the whole thing with that. You palpate the presenting part. If part is pushed upward and not engaged, where it's not 0 station, then you can push upward. If it's difficult, the baby's difficult to move, then the baby is engaged in the maternal pelvis. That's how you can see. For cephalic presentation, face mom's feet and use fingers to feel this fetal head is flexed. For text position, normal or extended. And these are just the steps on how they do it. So they basically just make their way around the fetus just to see how the fetus is presenting. We just want to see, is the head going to be coming out first like we want it, or is the baby breech where the buttocks is presenting first, or the fetus. So that's mainly what we're just wanting to see for, and these are just like the little steps for it and how they do it. They just work their way down because we just want to make sure that the baby is, the back is facing towards either right or left, and that the head is first. So we'll think with that. Prolapse umbilical cord is a true emergency. So the whole thing with prolapse umbilical cord is that the umbilical cord has slipped and now it has fell through the vagina, which is an emergency, because you want to remember the umbilical cord carries all the nutrients and oxygen to the baby, and if it has prolapse and now it's coming out of the vagina, it's not giving the baby the oxygen that it needs. It's not giving that baby proper nutrients or anything like that. The heart rate is going to drop on the fetal heart rate. And you're going to notice that when you look at the fetal heart rate on the screen. So this is when the umbilical cord lies below the presenting part of the fetus. So during contraction, stops flow of blood and compresses it. Primary risk factor is a higher station. So say, this just goes back to like station. So say the baby is floating, which means that the baby is not near the pelvis yet. The baby's like up more. Like I know the head shows it's at -2, but if the baby's floating, they're at higher risk. So that's near like over here. But when the baby gets to 0 station, the baby's no longer at risk for the umbilical cord being prolapsed because the baby's engaged, they're at 0 station. There's no, say the head gets to 0, there's no room for the umbilical cord to like make its way and prolapse. So the baby's floating within like the negative regions. So in the prolapse, umbilical cord kind of happen. So that's why it's a risk factor. From -1 to -5, the baby is floating. So they're at risk for that prolapse umbilical cord when those membranes rupture, when that, that amniotic sac ruptures. Once a baby gets to 0 station and the head is wedged, like I said, like between the ischial spines, the cord cannot come, so they're not at risk anymore. Assessment findings, so there's going to be a steady drop in fetal heart rate on monitor. So in the monitor, you're going to see that fetal heart rate going down. The membranes have ruptured. You do want to suspect a prolapse cord. All right, compressed blood flow to the baby, of course. And these are the nursing actions. So first, you're going to want to hit that emergency button right away. If the woman is on Pitocin or oxytocin, you follow rest of steps in order. You just want to stop the Pitocin and then go in this order. So Pitocin is the same thing as oxytocin. I don't know if you guys learned about that yet, but it's just a medication that they use to stimulate contractions. You want to stop causing contractions because that's going to make the problem worse at the moment. Only some women need Pitocin or oxytocin, especially if you're inducing someone. And then right after that, after you stop that oxytocin, you're going to want to do a sterile vaginal exam. But you have to do this really fast because this is an emergency. So you put on those sterile gloves and you're going to push the presenting part of the cord up. So if you're pushing the cord up, now the baby's going to be getting that oxygen and the heart is going to go back up. You're relieving that pressure on the cord. So once you do that, you can hear that fetal heart rate go up. But you cannot take your finger out because if you take your finger out, then it's just going to come right back down and then the baby's heart rate's going to drop. And then you're going to want to fix the mother's position. So head on bed and then tush in air. So let me find this position. So this is what you're going to want to do. You're going to want to like insert your fingers right when you see that this is happening, or even if you see the umbilical cord is out, you're immediately going to want to put on sterile gloves and then you're going to push upward and you're relieving that pressure so that it doesn't come out. And then the baby's fetal heart rate will go back to normal. So that's the steps for that. So you hit the emergency button. If she's on this medication, stop that medication. And then you're going to put on the sterile gloves very fast and push the presenting part of the cord up. You cannot take the finger out. And then she's going to need oxygen or an IV bolus. And she's going to need a C-section with this because, if she delivers vaginally, that umbilical cord is going to come out first, which we never want to happen. We need the baby to come out first, then the umbilical cord, then the placenta. That's how we want it to happen because if the umbilical cord's coming out first, then you're going to have a decreased heart rate and all things like that. And that's not good. Can lead to fetal demise if we have that baby vaginally. So C-section always with this. And there's different types. They're not too bad to remember. Just with occult, it's hidden, not visible. So you're not going to see the umbilical cord, but it has drops below the fetus. With overt, you're going to see that umbilical cord. All right. Fetal heart rate patterns. These get a little bit complicated. There's a little acronym I put down here. This is how my professor showed me last year. So it's VEAL CHOP, and then you have like your management. So it just helps you remember. I always say it in my head too, like just to remember. So what fetal heart rate changes may suggest umbilical cord issues. So these are variable decelerations when you're having like that umbilical cord's being compressed. If that baby's like lying on that umbilical cord and that umbilical cord is being compressed, it's oxygen's not getting to the baby because maybe the baby is lying on it. So we're going to see abrupt decrease in the fetal heart rate. And it's going to be very UV shaped, and it can happen with contractions or no contractions. So it's going to be like a rapid down, rapid up. It looks like this. Try to zoom in. So normally with like contractions, the fetal heart rate should look like this. So this one is normal, because you want to. This is signifying a woman's contractions. The bottom one. The top one is looking at the woman's sorry, it's not sorry. This one is looking at the woman's contractions, what she's having the contractions. This up here is telling me the baby's heart rate. So this is telling me that the baby, whenever a woman does have a contraction, the fetal heart rate does drop a little bit, not like a lot of it, but it does decrease a little bit, which is completely normal. That's just telling me that the head is being compressed. It's not a big deal. This is complete. Early decelerations are completely normal. Just know that it's normal when they match. So the fetal heart rate is decreasing when the woman's having a contraction, and look, they're mirroring one another. So you just want to make sure that they're mirroring one another. So this is normal. This up here is not normal because it's a rapid drop, and it's very U and V shaped. And this is telling me that this umbilical cord is being compressed. Right? And these are your treatment. So say the woman is on oxytocin or Pitocin. So Pitocin is just a trade name. Oxytocin is the generic name. These are medications that cause contraction. Some women are on it because maybe say they're 40 weeks pregnant, but they're not experiencing contractions yet. We need to induce them. If they're not on Pitocin, priority is to reposition the mother. So the main thing here, say we want to reposition the mother because the baby most likely is like sitting or laying on the umbilical cord. So we want to reposition the mother in hopes that the baby is now like off of the umbilical cord. You're going to give her oxygen, increased rate of IV maintenance because it does dilate blood vessels, and then notify provider if these interventions do not work. Or an amnio infusion may be indicated just to give more fluid within that uterus. So just know that the variable decelerations are not normal. They are an emergency, and you do have to act with this one. And the main thing is you just need to get that mother, you just need to change that mother's position to get that baby off of the umbilical cord. Fetal heart rate changes may suggest what fetal heart rate changes may suggest uterine placental insufficiency. So just look at the acronym. It still helps me to this day, like always, like remembering it. So late decelerations, veal chop. So placental insufficiency. This is never good. The baby can't handle strong contractions, is what it's telling me. So it's a gradual decrease in fetal heart rate after contraction has started. Prolonged return to baseline. So this is what it looks like. So like I said, it's normal if it matches, right? It's not matching. It's late. It's not happening like I said, this one's normal. They're matching one another. It looks good. Here, it's not matching. It's happening after the contraction. After the contraction. So this is just like, okay, she's having a contraction, and then it stops, and then she's having a contraction here. But the fetal heart rate is decreasing after the contraction, which is not normal. This is telling me that there's uterine insufficiency and placental insufficiency, which all that means is that there's a decreased blood flow going to the placenta. And whenever there's decreased blood flow going to the placenta, that leads to fetal hypoxia and can lead to fetal demise, so fetal death. So that's when the most pressure is when the placenta, fetal heart rate goes down. So this is just saying if you do not intervene, you may end up with a fetal demise. So that just means like the baby's gonna die. Priority here, you're gonna need to stop Pitocin or oxytocin if she's on that medication. If not on Pitocin, you're gonna want to reposition the mother, side lying, oxygen, increased rate of IV maintenance, because it dilates blood vessels. So like all the same things like we said. And then you're going to want to notify the provider if these interventions do not work. Then you're going to want to prepare for a C-section. So the main thing with this one is that the uterus is not being perfused the right way. And I'm sorry, not the uterus, the placenta. If the placenta is not being perfused, no oxygen, no nutrients, nothing to the baby. No oxygen to the baby, baby can die. So that's why you're gonna have to prepare for a C-section if the interventions aren't working. That's most likely what's gonna happen here. So most often, your late ones are very alarming. This is abnormal, very alarming, and not normal. This one's also as well. And then your professor just put compare early, late, and variable. So early decelerations are completely normal. It's the active phase of labor, so there's a gradual decrease in fetal heart rate with contractions, and they mirror one another. And all this is saying is that the baby's head is being compressed, which is normal, right? Like they're coming through the birth canal, so of course their head's gonna be compressed coming through the birth canal. It's completely normal. It's benign. There's no intervention required. Like you don't have to do anything. This is completely normal. All it's telling me is that she's having contractions. That's all it's telling me, that she's progressing with the labor. All right, but you would just want to document that it happened. You're documenting that she's having contractions and that the baby is being pushed through that birth canal. When contraction is over, the fetal heart rate goes back to baseline. So it goes down and then it's back to normal, goes down, back to normal. But they do have to mirror one another. So identify labor progress. So anticipate she'll be complete soon. Reassuring. So this is reassuring. This is just telling me that, labor progress is being made, the fetal head is being pushed against the cervix, and that effacement and dilation are occurring. So all you would do is document this happened. It's completely normal. We want this to happen. It's telling me that, she's progressing with the labor and, she's probably gonna have the baby soon.
So variable and late decelerations, that's not normal. Like that's a medical emergency. But early, that just shows an indication of progression of labor.
Yes. Yeah. So
Okay.
completely normal early. It's just telling me the baby's head is being compressed. And I know, like, I was confused at first when I learned this last year. I was like, the baby's head's being compressed. Isn't that, abnormal? But it's not, because the baby's head, of course, has to be compressed when coming through that birth canal. You know, it just has to be compressed. So the fetal heart rate will just decrease when the woman has contractions. It's completely normal. We do want to see this though, just so we see that the mom is progressing through labor. But the other two, they're very alarming. But just know the difference, because even your professor like wrote it. Just know the difference. Like late is due to the placenta not being perfused. So I honestly would say this one is worse, the late one, because you're most likely, you say the interventions don't work, there's going to be a C-section. But with variable, we'll notice it. It is alarming. And if we don't act, then baby could die. But usually we're just gonna reposition that mom just so that the baby can get off of that umbilical cord, because most likely the baby is just laying on it and then it's decreasing its heart rate, it's decreasing the amount of oxygen getting to the baby. Most often we're just going to do reposition the mom, and usually that'll just work. If it doesn't work, maybe a C-section, but most often you're just gonna reposition the mom. I would say late is worse, because it could be like an underlying problem where the placenta is not being perfused correctly. And you might even see this with preeclampsia, because there's so much vasoconstriction happening where the placenta is not being perfused. So this one would definitely be more alarming. This one we can just like reposition the mom, hopefully, and that will get the baby off of the umbilical cord. And then I just put the same thing because your professor just said to compare them. Yeah, these are the same notes. And this acronym does help. Like I still say it in my head all the time because it's a lot. And even this, I never memorized the management, but definitely would be very like very helpful. I always say veal chop in my head when I'm like, even like, because I've been doing like NCLEX questions, and whenever I hear like placental insufficiency and it's like asking which one it is, I always go back to this acronym. It's always going to help you. Do you feel okay with the fetal heart rates?
Yes.
Did your teacher teach about like these pictures or not really?
Yeah, she did teach about decels, but I was kind of confused, but you explained it good, so thank you.
You're welcome. Just know that these ones sometimes it could get confusing, like, oh, like maybe they're mirroring, but look, it's not really mirroring, and it's more very sharp. It's like U or V shape. That's just a little difference. Because my teacher last year, she put pictures on our tests where we had to like pick which one it was, but I don't think they're too bad though. All right.
Oh,
So
and so for early deceleration, like the dips are not as bad, right? And they match?
yeah, so it's not
Okay.
as bad. It just the baby's heart rate just decreases a bit, and it just mirrors. The main thing is that it has to mirror. Say that this is like happening after it, that would be a late deceleration. Does that make sense?
Yes.
Okay. Let's see. Shoulder dystocia. So this is an emergency as well. So this is when the baby's shoulder gets stuck behind the mother's pubic bone, so the baby's not able to come out. So it is an emergency because the baby's like right there, and now the baby's like going back up into the birth canal. So your professor just put I just put everything in red that like your professor put on the blueprint. So your professor wanted to know like a sign indicating this, and then the maneuvers you would do as the nurse. Um, so it's unpredictable and unpreventable OB emergency. So any woman who's having a vaginal birth is at risk for it because you never know if the baby's shoulder could, possibly just get stuck behind the pubic bone. Um, so it's delayed or difficult delivery of shoulder after birth of head. So when a baby comes through the birth canal, head will come out first, and then the shoulders don't actually come out during the same time. So one shoulder will come out first, and then the next one will come out after that one. So they never come out at the same time. So it's gonna be one shoulder and then the next one. So either one could get stuck behind the pubic bone. Syphysis pubis, so failure fetus to complete external rotation. Um, so these are hints that a woman is having shoulder dystocia. Macrosomia. So say the woman has gestational diabetes. Like I said, those babies are at risk for becoming macrosomic. So big babies. Macro means big. So think, and soma means body. So the big babies. They're at risk for getting stuck behind the shoulders getting stuck, or the baby getting stuck. The baby can't fit through the birth canal. Things like that. Prolonged second stage. She's been pushing for hours. But the main one here, I believe your professor wants to know is turtle sign, because that's like the main thing. So basically, like, how turtles, like, they, you can see their head 1 minute and they go back into their shell. So it's sort of like that. You're going to see the baby's head come out, and the baby just goes back into the birth canal, and you no longer see the baby's head. So it's basically like, okay, the shoulder is stuck. That's how the shoulder is stuck. The baby cannot come out because it's stuck. So it's going back in the birth canal. So maternal complications of this is moms who have shoulder dystocia will end up with an episiotomy. It may end up with a laceration or spontaneous tear or postpartum hemorrhage. So say we did all these interventions and it didn't work, we may have to do a episiotomy. So this is when, they're basically cutting down the vagina and they're going all the way to the rectum. Sometimes they go all the way to the rectum, and what that's going to do, it's going to cause like a bigger, wider area for the baby to now come out. So in worst case scenario, they're gonna do this. Most often they will do this. We'll do the maneuvers as the nurses, and then the doctor is gonna cut, from the vagina towards the rectum, which is gonna be painful for the mom, especially if she hasn't had, any epidural or anything. But whenever with an episiotomy, there's always a risk of, she's postpartum now. There's a risk for a hematoma developing, which is a collection of blood. But there's also a risk for, she's bleeding a lot from this site, so postpartum hemorrhage. So if she's having an episiotomy, which is that cutting, which is definitely very painful, postpartum, she's at risk for hemorrhaging, which is, bleeding profusely, losing a lot of blood, hypovolemic shock, and all of that. I think that's on your second quiz. I think the other section had that on the second quiz. Yeah, so that's that. All right. So complications for newborn. So the longer the baby takes to come out, the baby's gonna experience hypoxia. They can fracture their clavicle because the shoulder keeps hitting the pubic bone and it could just like snap. The OB is the obstetrician in the room, the doctor is gonna be trying to get that baby out, like, sort of like pulling on it after they do that episiotomy, which gives them more like visualization, but also gives them more room for the baby to come out. The bone can break, and also unilateral nerve injury can happen on that side of where it's stuck because the obstetrician's going to be, pulling and everything like that, or if the baby is just staying there, and not coming out. So these are like the steps on like what you would do. I believe your teacher wants you to know the maneuvers you would do. So your first step is going to do is call for help and hit the emergency button. You're going to do that. And then the doctor is going to evaluate for an episiotomy. So usually the OB will already be doing an episiotomy because we want to enlarge that perineal opening. So if we enlarge that opening, you cut from the vagina to the rectum, you have a bigger area to work with and a bigger area for that baby to now fit out of. And then you as the nurse, this is definitely the maneuver you want, your teacher wants you to know. It's called the McRoberts maneuver. So 2 nurses will stand on either side of the mother and just bring her knees to her ears. And what that's going to do is going to cause a bigger diameter so the baby can fit through. And then the legs are going to be in this position, and then another nurse is going to be pushing down on the pubic bone to help push the shoulder out. So we're going to try this 3 to 4 times. Hopefully it works. If it doesn't, emergency C-section. Rotational maneuvers OB would do just to get that baby out. Remove posterior arm, the OB is going to do. And then you're going to roll the patient to her hands and knees to get, the baby out. I'm going to show you a picture of this maneuver. So this is what it looks like. You're gonna suspect it, and then both nurses are gonna be, trying to get the knees to the ears. Just really like enlarge that diameter because it's gonna give more visualization, widen the diameter of the vagina just so you can help, get the baby. Just because there's not enough room for this baby to come out, we need a bigger diameter. So do that, and then the suprapubic pressure. They're gonna do this as well at the same time. Just keep like pushing and putting a lot of pressure so that we can just like get that shoulder out where it's stuck. Oh wait, wrong thing. Yeah, and then you do those maneuvers. Your teacher's definitely gonna test you on this one, the McRoberts one, because I was testing that one too. It's the main one here, or the suprapubic pressure the nurse would do. But the OB is the one who's going to be doing, the maneuvers. They're going to be by the vagina, like trying to, maneuver the baby's way out, remove the posterior arm of the baby, things like that. Roll patient to her hands and knees, help get that baby out. So that would be the last position. But this is the maneuver you would need to know. Next is postpartum assessment. You just want to know your expected postpartum findings for fundal height, lochia, and the breast. So the fundus is the top of the uterus. I feel like some people don't know that. The top of the uterus. It has to be midline, firm, and at the umbilicus, so at the belly button following birth. So say she gave birth vaginally or C-section, it does have to be at the umbilicus, and decreasing 1 centimeter per day. And then the fundus should actually be back to normal and behind the pubic bone in about 12 to 14 days. So the uterus should not be palpable at all after 2 weeks. If it's palpable, it's a really bad sign. It can, tell me that this patient is hemorrhaging possibly, which is a medical emergency as well. And whenever you assess the fundus, so if you ever want to work on like the mother baby or postpartum unit, you definitely need to just know this into how to assess the fundus. So just know midline, firm, and decreasing 1 centimeter per day at umbilicus following birth, and just decreasing 1 centimeter per day. After 2 weeks, we should not be able to palpate that fundus, not be able to palpate that uterus. And whenever you assess it, you want the patient to have an empty bladder. A full bladder can actually cause the uterus to tilt to the right or left, and that can actually contribute as well to postpartum hemorrhage. Lochia. So a woman following giving birth, either C-section or vaginally, she will be, bleeding like she's on her period a bit. And she's bleeding at the site of where that placenta is. So the mother just gave birth to her baby, and then she basically gave birth to the placenta as well. And where that placenta was, the placenta was attached to the uterine wall. But she just, delivered the placenta. So she's bleeding at the site where the placenta was. And it does need to occur in this order. So, rubra, days 1 to 4, right after you have the baby, it'll be bright red blood. And it may have clots in it, and that's okay. As long as the fundus, as long as, the uterus is firm and midline. And it does have a characteristic odor. Next, around days, it looks weird, but I just meant to say days 3. I don't know why I did that. Days 3 to 4, to 10. It's gonna be like a pink brown color, and that's known as serosa. It's like a vocab word. Alba is after day 10, and it's a clear color to white or light brown, and it can last for weeks. This is a picture. So a woman should never be saturating her pad like this, like a bright red color like this. If she is saturating a pad like this, in like an hour, that's very alarming. That's telling me, and that's a sign of postpartum hemorrhage. And that if the uterus is not firm and it's soft and boggy and it's not midline and she's saturating the pad, that's a sign that she's hemorrhaging, and we're gonna have to start a fundal massage just so that she continues contracting. And putting pressure on those vessels where the bleeding is occurring. If
So
we
this is like the stages. Oh, sorry.
No, you're okay.
These are like the stages of the not the discharge, but the liquid coming out of the vagina to see if it's I don't know what's the right word, but
Yeah,
if
it's
it's
just
okay.
yeah, so it's just like just saying like how she's healing properly. So we just need to occur in this order. So of course, like after she's just given birth, it'll be bright red, but it should never be bright red on like day 10. So it's just like saying, okay, the site of where that placenta was, it needs to heal properly. So it'll be bright red, and then it should, get to like a pinkish brown, and then to like a clear white color or light brown. It should just not consistently be bright red, because that would just be telling me that she's losing a lot of blood. So the site of where that placenta was, there's a lot of bleeding occurring at first. But we want constriction to happen over there. So we want them to be contracting. Whenever a woman has just given birth and she delivered the baby and she's delivered the placenta, we administer oxytocin, which is a medication that causes contractions. For every single woman in the U.S., the woman will be getting oxytocin following giving birth, and we're causing contractions, and it's causing constriction of where that placenta was. It's like decreasing from bleeding too much from there where that placenta was. So that medication helps with that. Um, so that's why, that medication helps with that. And this is just telling me how that placental site is healing. So if it's super, super bright red on like day 6, that's alarming. That's a sign of postpartum hemorrhage. She's saturating those pads. Like say it's like an amount like this on day like 4. That's completely normal. It's fine. But say it's day 4 and it's like this, it's a sign of postpartum hemorrhage. She's losing too much blood, and she's at risk for hypovolemic shock and all things like that, and death. Um, so it's just all just how she's healing from that site. Does that make sense?
Yes, thank you.
You're welcome. Um, so yeah, just the woman is experiencing postpartum hemorrhage, and that's an emergency. We have to act fast. And then breaths, they should just be soft filling and firm. Um, All right. How do you distinguish normal versus abnormal findings? So at Lokia, we make sure it's happening in the right order. So we want to make sure that it goes rubra to serosa to alba, and it correlates with those days. That we're not having rubra on like day 6 or anything like that. We also want to assess for clots. It's okay if she has clots, but as long as the uterus is firm and um, midline and all things like that. We would worry if it's super heavy. So if she's saturating a pad in less than an hour, that should never happen. She should not be like saturating a pad like this. That's very alarming. And bright red too. Uh, if she's bleeding that much, assess the uterus. Uterus is, if it's soft or boggy or mushy, that's not normal. You, as the nurse, what you're going to have to do, your first thing is going to be massaging the fundus. And if you're massaging the fundus, you're basically just like reminding the uterus like, hey, like you need to contract now. You can't be relaxing. You need to contract so that you are constricting those arteries that are causing the bleeding. Because by bleeding, there's so much vasodilation occurring, but with contracting, you're causing that vasoconstriction. So after a woman gives birth, we actually do want them to continuously contract even after they've given birth, because it's helping prevent postpartum hemorrhage. So that oxytocin is going to help with that, but also that fundal massage too that you're going to be doing as the nurse, if that uterus is soft, boggy, or mushy. And of course, we can document your findings. Lochia is a medium for bacterial growth. So say she has her peri pad on, that's what they call it. It's just like a pad that, we use for our period. So it's like, say you're not changing that, they're not changing their pad a lot. And say they wore it for like 10 hours, that's not good. We do want them to change it pretty frequently, just because, when anything just stays and becomes stagnant, bacterial growth can happen. So she does need to change her pad like every 2 hours. And a peri bottle also happens where they just like spray like on their vagina, and it just like helps like clean it and everything, prevents like bacteria and things like that. Just to keep that area as clean as possible, prevent infections, all things like that. And be aware of possible complications. So call if you do want to do patient change. So you want them to call if their lochia changes, gets red all of a sudden, especially if they're at home. So usually we'll see if a woman's postpartum hemorrhaging like within the first day of after she had the baby, but sometimes they are at home after 3 days and they could be hemorrhaging. So they should always call if it's like bright red. It can indicate a possible hematoma, which is a collection of blood. Or a postpartum hemorrhage. If she runs a fever, so a sign of infection, any sign of infection. This is just saying the same thing. So following delivery of the baby and the placenta, the fundus should be firm, midline, and located at the level of the umbilicus. If it typically descends approximately 1 centimeter per day and should no longer be palpable by 2 weeks. So if the fundus is soft or boggy, this is concerning for uterine atony, which is uterine atony is just a fancy word for saying like the uterus is not contracting and it's just very just like sitting still and everything like that. A major cause of postpartum hemorrhage. It's just saying that the uterus is not contracting. We do want the uterus to continuously contract even after giving birth, just to prevent that bleeding. A fundus that is not midline, often deviated to the right, may indicate a distended bladder, like I said, which is not good, which prevents effective uterine contractions. So that like a full bladder. So this woman should be emptying her bladder pretty frequently after giving birth, because we don't want it to deviate and cause a postpartum hemorrhage. Additionally, if the fundal height is not decreasing appropriately day by day, this may suggest subinvolution. So nursing conditions include massaging the fundus, like I said, because you want to remind the uterus, hey, like you need to contract, you need to vasoconstrict to prevent that bleeding from the site where that placenta was. And then you want to assisting the patient to void if the uterus is displaced to the right or left. Monitoring lochia and vital signs, and properly reporting any signs that may indicate postpartum hemorrhage. All right. Episiotomy and perineal care. So this is an episiotomy like I talked about before. So that's when the doctor, they'll do this with that shoulder dystocia, but they can also do this if that baby is like very large, like a macrosomic baby, and the baby's not really fitting. We can do this to widen the area just so the baby can like come out easier. But there are certain things. So postpartum, we're gonna want to assess that area. So assess it for redness, ecchymosis, which just means bruising, edema that can indicate infection or a hematoma, discharge. It shouldn't, be bright red at like day 6 or anything like that. Approximation, that the suture lines are together and they're not coming apart or anything. Any of these things, if they're not normal, that's a sign of infection or inappropriate healing. Expected findings after an episiotomy: mild edema, minor bruising, approximation of edges. Because after they do this, they're gonna suture her up. So those edges of those sutures should be, well together. And of course, she's gonna be in pain. This looks very painful. And complications: excessive swelling, infection, hematoma, bleeding, all things like that. What comfort measures are used for episiotomy pain? That's what your professor wanted you guys to know. So with the first 24 hours after she's had that episiotomy, the doctor just sutured her up. You do want to put ice packs to that woman, the mother, and this helps decrease swelling. It helps with that bruising, helps with pain. After 24 hours, you're gonna stop the ice and go to a sitz bath, which is basically they're just gonna like sit like on the toilet, and it's basically just like a shower to her tush. It's like a certain setting. It's like a swishy action, so it's like washes all away the dead cells and all things like that. It helps keep it clean, things like that. Witch hazel pads, peri bottle. This basically they're just going to like like squirt the peri bottle and then pat dry. This removes like any type of lochia, because excess lochia can cause, like, especially if you leave it there, it can cause infection. You just want that area to be clean because this is a surgical site and you always want to make sure it's clean. Not like a surgical site, but they are cutting an incision and then suturing up. So it's sort of like a surgical site where you just want to make sure that she's healing properly and everything like that. Um, um, so the main thing is just preventing infection and just making sure that this woman is comfortable. So all those things, that ice pack, sitz bath, help with that, but they also the sitz bath can also help prevent infection. Sitting measures: if a woman has had an episiotomy and if she sits down, her sutures are going to pull. So you want her to not get those sutures like out of whack or like gapping. So before she sits down, she should, tighten her pelvic floor muscles like a Kegel exercise. So think back to like med surg. And then you want her to like sit down, hold that Kegel, so tight tush, like basically it's like clenching, and then come down on one side and then the other, and then relax. So this is just preventing those sutures from coming apart from that episiotomy. Or she can just lay on her side in bed. We can do topical anesthetics just because she is going to be in pain. It's going to numb the perineum. Pain meds ordered. NSAIDs are always the best, especially if they delivered vaginally because it just targets the uterus. If the woman has had a C-section, we usually do narcotics. This has nothing to do with episiotomy. It was just like a note my professor said last year. But NSAIDs for pain for this episiotomy. Reduce risk of infection is the main thing. So hand washing and frequent changing of that peri pad because she is going to be bleeding still, right? She's still going to be lochia on that pad. So frequent changing because now she has a suture line she has to take care of and prevent infection. So that all helps with preventing infections. Signs of pregnancy. This is just presumptive, probable, and positive signs. So presumptive is just the woman thinks she's pregnant because she's having all these signs and symptoms: nausea and vomiting, fatigue, amenorrhea, which means no period, urinary frequency. That usually happens in the first trimester. Breasts that are tender and swollen, quickening. She feels the baby moving. That's a little vocab word. Skin hyperpigmentation. Some women have like skin changes on their faces, which indicate pregnancy. Probable signs that are seen by the provider. So I know your professor did put this. I saw this in the PowerPoint. So it said Heger sign. So that's softening of the lower uterine segment. Chadwick sign, which is the bluish purple coloration of the vaginal mucosa, and cervix. So it looks bluish or purple, that cervix. Goodell sign is softening of the cervix, because we do want that baby to come out nicely, and a softening of the cervix helps with that. Positive pregnancy test is probable sign. Because remember, positive pregnancy test, it's like 95% accurate. It's not 100% accurate, but it's 95% accurate. So it's not like a definitive sign. Abdominal enlargement, Braxton Hicks contractions, allotment. That's when the provider puts their finger up into like the vagina, and they push on that uterus, and it bounces up and it comes back down like the baby. Positive, so we're like, oh, we're sure that she's pregnant. Fetal heartbeat, ultrasound, fetal movement felt by provider. But this one is just like, this is seen by the provider, but we're not 100%. Here, we're 100%. GTPAL documentation. So if you ever seen a epic chart on labor and delivery unit or mother baby, you'll always see like this, how are pregnancies and outcomes documented. So Gravida, your teacher might give you like a scenario where you have to like, write out or like solve like, okay, what is the Gravida? How many term pregnancies has this woman had? How many preterm pregnancies has she had? All things like that. So Gravida is just the number of total pregnancies, including the current pregnancy. So say she's pregnant right now, but she has 3 kids. Gravida would be 4. It would include the current pregnancy and all the previous pregnancies she's had. And Gravida, say she's had twins. So she has twins and she's pregnant right now. The Gravida would only be 2 because she's only been pregnant twice. Term is just how many term births she had. Term births are 38 plus weeks. So that's like 38 to 40, baby is term. Preterm is 20 to 37 weeks. That's a preterm baby. Abortion, that could be induced or elective or spontaneous. And then living is how many currently living children are living right now. Spontaneous abortion, what are the categories and characteristics? So there's different types. So threatened means the signs and symptoms of a threatened miscarriage include light bleeding, no cervical changes, mild cramping, and no passage of fetal tissue. Inevitable, moderate bleeding, there's cervical dilation, rupture of membranes, strong cramping, no passage of fetal tissue. Incomplete, the signs and symptoms of an incomplete miscarriage include heavy bleeding, cervical dilation, severe cramping, and the passage of some fetal tissue. Complete is where she's completely like basically just delivered all the contents of the baby and the placenta as well. How are they managed? Continued assessment. Is she bleeding or is she spotting? How much pain is she having? Is there cramping and contractions happening? Passage of products of conception, but that just means like the baby, umbilical cord, placenta, and all that. What are the vital signs looking like? Assess amount, color, and characteristics of bleeding. You do want to give her some psychological help and psychological support for loss and grief. And then you, the nurse, you're gonna draw blood. And remember, HCG is your measurement of pregnancy. So those levels will be high in the blood. So a pregnancy test actually looks for these levels. And if it's high, it'll mark that pregnancy test positive. So it's looking for this. So when that woman is having a miscarriage, you will see these levels decreasing. And then CBC, maybe if she's lost a lot of blood after having this miscarriage, maybe the hemoglobin hematocrit will go down too. I wouldn't focus too much on this yet, because this is going to be on your next test. RhoGAM just deals with if the mom's Rh factor is negative, but the baby's Rh factor is positive, and they're just not compatible. So we would have to administer a shot just so that the mom doesn't reject the baby in the future pregnancies. But it wasn't on your blueprint, so it's probably on your next test. So don't focus too much on that. What is the most common cause of spontaneous abortion? So it's gonna be chromosomal abnormalities. The most common cause. I actually had that question last year too. It's just chromosomal abnormalities. What medications or procedures may be used? So say the woman, she had a miscarriage and that baby is still in the uterus, no heartbeat. Um, they may give her a medication called misoprostol. This medication we actually give to women who are being induced. This is a medication. It's known as a cervical ripening agent. It basically just like causes dilation of the cervix. So of course, like if say she has a baby in her uterus who died, we're gonna want to dilate that cervix so that she can pass that baby through her uterus. And then they're most likely gonna do a procedure called dilation and curettage. So if you ever see DNC, that just means dilation and curettage, where they're going to dilate the cervix, maybe with misoprostol. That medication can help cause dilation of the cervix, which we need for that baby to come out. And curettage is basically when they just scrape the placenta out. They scrape, all the contents of the fetus out. The fetus is coming out. They're scraping the placenta off of the uterine wall. So dilation and the curettage, they're scraping it out. Molar pregnancy. Um, Honestly, I've never learned about molar pregnancy, so I'm not honestly not too sure about it. I never even had like any questions on like Archer or anything. But I just found these notes, and I think there's a Level Up RN video on it. She's really good. She's very ATI based, so maybe watch the video on that. And I hear she's really good with like ATI. I always watch her for all my classes just because she's very ATI and NCLEX based. So she probably would help with that. I really don't know anything really about molar pregnancy. And I think that's it. But thank you so much for coming. If you have any questions, feel free.